So the case that I'm going to present is an imaging case, and it's a case of what you don't see is what you get. So these are my disclosures, but Neil's, my main disclosure is I'm actually from Tasmania. So for the domestic audience, they know that's David Boone, that's Ricky Ponting, and dare I say that's Tim Payne. But this is a 42-year-old man who some years ago presented with a non-ST segment elevation ACS. His ECGs and echo were consistent with the circ culprit.
Not playing.
And you can see a fairly discrete lesion in a large separate origin circumflex artery, really codominant circulation. The LAD and the right coronary arteries were free of any significant obstructive disease. So this was a young man. We had a very active biodegradable program involved in Absorb Extend, Absorb 4, Biosolve, and in this case we enrolled him, given his age, to receive a phantom scaffold. So that's the Riva device Phantom 2 trial. So this is a sirolimus-eluting tyrosine-derived polymer. It's not Absorb, it's not polylactic acid. And a 3.0 device we chose and optimised with a 3.5. So this was implanted angiographically. The trial devices we had were either 2.5 or 3.0 and either 18 or 24 length. So this is a 3.0/18 being implanted. Here it is optimised with a non-compliant 3.0 and then 3.5 balloon to high pressure. And angiographically, we're pretty happy with the results. This is the run. Angiographically, you'd be happy with that. But I encourage the operator to OCT at the end. If I can try and take this through. Now, I was the primary investigator for our site. This was the co-investigator, so I take all responsibility for this. So we come through to the scaffold, and we can see the broad scaffold struts shortly. And there they are. That's the classic tyrosine polycarbonate, broad, thickish scaffold struts. But if we go back proximally, and we're going to see that it's really malopposed. It's really quite off the wall at the very origin of the treatment segment. Coming up to it now. There you go. You see it really nicely, really undersized. So this is imaging during, not before. So that's it in a still. So we've really undersized this device. It's a 4.4 it's a 3.0 to 3.5 in a 4.4 to 4.5 vessel, EL to EL. So this is the 3D navigation, really showing this broad arc of malapposition in a big vessel, and not on the wall. So this is setting up an issue. So this was now re-optimised with a 3.75 millimetre balloon. So with the Riva device, unlike the Absorb, we could go 0.5 larger, so we went 0.75, acceptable, part of the device post-expansion capability, but that's the limit. So angiographically, again, we're happy. So having done that, again, encourage the operator to image, see what's going on now. And a little difficulty passing the OCT catheter on this occasion. But it went, it was not a drama, and I'll pull back through the distal vessel, our distal landing zone's good, and we come back up in to the more proximal scaffold, and we're going to see some activity. Across the side branch, a little bit of tissue, but otherwise pretty good. You're about to see some struts. There you go, some struts in the lumen, free-floating struts in the lumen of this tyrosine device, coming more proximally, more struts. And in what you're seeing, I won't go back to that. I've got a still frame here. There's the struts in the lumen very proximally, almost at the front margin of the device. It's peeled completely off the wall between 9 o'clock and 1 o'clock. And again, osteally, still really significantly malopposed. So this again is the 3D navigation, and we can see down on the L profile, the L mode, you can see the struts in the lumen. This is a marker, but if we go to the 3D navigation, we can see here it's been peeled off the wall. We can see what's happening. If we sort of rotate, not only is the device being peeled off the wall, we can see tongues and accounting for our cross-sectional appearance pulled back into the lumen. And you can see it even more obviously in this still shot in the 3D nav. So imaging is really resolved what's going on. And without imaging, we would have completed the case because it looked good angiographically. So what to do next? I think at this point we advocated actually just stenting it. Put a metallic stent in. This is an Ossero sirolimus-eluting stent, 3.5/18, optimised with a 4.0. Again, it looked good angiographically. We'll pull through. You start to see it mostly overlaps throughout most of the device. We've got covering nearly the entire BRS device, the Riva. But interestingly, again, good lumen throughout. Interestingly, as we come up to the proximal segment, we can see a chunk of the tyrosine scaffold prolapsing quite obviously into the lumen. You saw it there, it doesn't, and you can see it here. Still malopposed proximally. You can see it quite obviously on the 3D navigation. It's really quite an elegant display of tissue prolapse, but the tissue in fact is the bioabsorbable scaffold falling through the struts of the Ossero stent. So another round of optimisation now with a 4.25 balloon. Again, angiographically throughout, it looked very good. I'll pull up and show the run through. So now, good optimisation throughout the device. It had some malapposition mid to distal initially. It's responded, coming up proximally. Still a little tissue prolapse, but less evident coming back into the proximal. There's the tissue prolapse. Good apposition expansion now. Now we're happy. So this is it at the end. We've got excellent MSAs. We've got negligible malapposition throughout the device, restented, and the ostium's now opposed. So that's the final result. Angio, and now we're happy with the imaging. And the patient's been asymptomatic now over 5 years down the track. I was really keen to try and re-evaluate this with OCT, but patient's obviously asymptomatic. It's a little difficult to justify a re-invasive assessment. So what actually has happened here? Almost certainly when the operator withdrew the 3.75 non-compliant balloon, he's induced quite severe longitudinal device distortion. So this is a separate origin circumflex artery, so it's analogous to a left main in terms of LSD and the interaction between the guide catheter and the device. So as he's pulled the balloon back, he's withdrawn the guide deeply, and it's abutted on the scaffold, and it's interacted with the scaffold eccentrically. And this is what I think we see here. This is following the initial OCT run. We see the guide cath with the arrow as it's pulled into the device, and now we've interacted with the device through it's a broad arc of malapposition, inducing that quite profound deformation and tongues of struts into the lumen. And if we'd left this with late dismantling, almost certainly this was thrombosed. I think we'd have been lucky if we got away with it. We would have been very lucky if it was just restenosis. We know that late dismantling of poorly applied absorbed struts was a predictor of late scaffold thrombosis. Well, this is big struts sitting in the middle of the lumen. So if we look at longitudinal stent deformation, and I acknowledge my colleague Mark Pitney, and this is actually the very first publication of longitudinal stent deformation. We didn't have the elegant John Ormiston descriptor of longitudinal stent deformation. We called it major stent deformation, pseudo-fracture, and it was observed with the stent we were using at the time, was the microdriver Endeavour platform. And this was completely incendiary for Eurointervention. They were very reluctant to publish it, and they ultimately published it, and the editorial board created a waiver that they had absolutely nothing and no impact on the commercial context of this publication and no medico-legal complications for them. So, but we got the elegant data from John Ormiston from New Zealand, and he actually showed all stents are potentially vulnerable to longitudinal stent deformation, and those particularly at risk related to connector numbers, particularly two connectors, connector alignment, the strut thickness and the strut alloy. So, Medtronic relaxed, and suddenly there was a litany of publications, particularly with Element, because it's a two-connector stent, and the data from John showed the alignment made it more vulnerable. But it's across the board of all of our devices, and we understand that now, particularly with putting stents in the ostium of the left main. So reducing the number of connectors and thinning the struts improves deliverability, but at the cost of longitudinal strength. We went on and actually showed beyond those technical aspects to the stent design, possibly as important or more important is apposition. So if you oppose your stent proximally, it doesn't matter what the design, including a driver, integrity, element, vision, and so forth, that you're relatively resistant to deformation. But if you're malopposed, you're really exposed a vulnerable stent, such as the element. And so that's what we've seen with our patient. Gross malapposition, guide coming down, undersized, had that complication. So in summary, take-home messages. This was severe scaffold deformation. It was not evident angiographically, and it was largely preventable. If we did an image, we would have left the lab with a major problem. So pre-PCI imaging allows planning. Select the appropriate device here, which would not have been a Riva because we needed a much bigger device. It would have been a DES, and then balloon optimization. So, as we know, we need to image before, during, and after MLD max algorithm, not just take a half-baked approach and think you can just define it afterwards because we've already made the mistake with the wrong device. So longitudinal stent deformation predictors do obviously include stent connector number, alignment, alloy, strut thickness, but importantly, apposition. And I'll finish again with a comment that imaging guidance only improves outcomes with PCI when the interventionalists actually understand and react fully to the data. So thanks again, and thanks for the opportunity to be here in Cochin.